This is simple. Can you turn on the share screen, Dr Hanh?
Sorry, Hunt, do you want to try one more time? I changed the share screen option so that everyone can share it. You want to give it one more try? Oh, perfect. Okay.
So now, can you see my PowerPoint?
Yeah, we can see yours.
So we start now, or wait a minute.
Dai, what do you think? Dr. Dai, should we just get started? Okay, Dai, we're going to get started. I think we can get started. It's 6:03, so we can get started and anyone else can join in.
Yeah. So hello, I'm Hanh Vo, an EM doctor of Dr Hanh Hospital. Today we'll talk about some main electrolyte abnormality like hyponatremia, hyperkalemia, calcemia, and phosphorus. So this is a very long and hard topic. So thank you for Dr. West very listening for initial development of this slide. They are very short and easier to understand. So now we go to the question first. So which is the following the potential cause of hyponatremia? I can do the roll now. So anybody have question? I have the answer. Yeah, I see on the chart. Yeah, the right answer is on cause both can cause the hyponatremia. So Hyponatremia is defined as the serum sodium level lower than 135 milliequivalent per liter, and one of the most derangement in ED. So now we will talk much about the hyponatremia. That being said, hyponatremia or low concentration of sodium in the extracellular fluid, and therefore the blood can be caused by either losing more sodium than water or gain more water than sodium. And it can develop acute over less than 48 hours or chronically over more than 48 hours. And the earliest thing we do after we testing for hyponatremia is check the osmotic pressure. According to the serum osmotic, hyponatremia can split in three categories. The first, sorry. The first normal osmolality between 200, 280, 280 and 285 milliosmol per kilogram on the word phone hyponatremia or pseudo-hyponatremia. This is where the body water and sodium level are normal, but there are an excessive amount of lipid like hypertriglyceride edema or protein like multimyeloma. And the second, when the serum osmolar is above 285 milliosmol per kilogram, we call that hypertonic hyponatremia. And remember that other osmotically active solute can make the extracellular compartment hypotonic. That cause water to shift from the intracellular to extracellular compartment. Such osmotically active solute can be the excess glucose in the DKA or the mannitol when we treat the several edema, or as well as the lysine and sorbitol. So, and the last category, when the lower serum osmolar below 280 milliosmol per kilogram, and it confirms the true hyponatremia, and it can further divide into two subcategories, depend on the body volume status. So the first subcategory is the hypovolemic. The hypovolemic, where there are numerous injury of total body water, and which is a less significant injury of the total volume sodium. Typical, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome, with all the patient with edema. The secondary subcategory is hypovolemic hyponatremia, where there is a small degree in total body water with a large degree of total body sodium. This can occur conditions like diarrhea, vomiting, or in response to certain medication like diuretics. And another more condition is cerebral sun wasting. And the third subcategory is volemic hyponatremia, or normal volume hyponatremia, which is where there not normal body sodium and increase the total body water. However, it's called volemic because there is no edema. Volemic hyponatremia can split into case with dilute urine or concentrated urine. Can you see in the slide? But remember that in case of hyperglycemia, make sure you corrected the sodium level by the formula. So the hyponatremia can cause symptoms like nausea, vomiting, or muscle cramp. In severe hyponatremia, water moves within the brain cell and they swell up, causing cerebral edema. This can cause confusion, coma, or even death. It can also cause increase the intracranial pressure, which can swap the blood pressure heading in and out the brain, causing ischemia, as well as possible brain hemorrhage, which can delay the respiratory center and cause the respiratory failure. Most hyponatremic patients do not require breast manager in PD if they don't have a symptom. But the severe symptom depend on the rate of the change of sodium concentration. If the uh, sodium level is dropped down very quickly, they can cause severe symptom. And now we go to another question with a female patient with history of hypertension on hydrolysis come into the ED department with mental status and headache. Shortly on arrival, she been seizing, and we do a blood gas with the sodium so below. So, which is the proceeding next step in the treatment? Should we load the 2 gram of Kepra or give propofol or give phosphonatrine, the sodium decat, or just the fluid? Yeah. Anyone have an answer? So the right answer is D. We will admit 2 arms of sodium picard because the patient have a severe hyponatremia. She have a headache, she have an antemental and seizing, so she need intensive treatment. So if the patient have a no sodium level lower than 125 millicurie per liter, with seizure or antemental status, we will admit to we will admit hypersaline like 3% hypertonic sodium chloride. If we don't have a hypertonic sodium, we can admit the sodium picard. The goal is raise the serum sodium to 4 to 6 millicurie in the first several hours to correct neurologic detention. Serum sodium should not be rise more than 10 millicurie over first 24 hours to avoid the osmotic demyelination syndrome. If the hypertonic saline is not available, we can give sodium bicarbonate 2 milli per kilogram in IV. So just in this slide, we just remember it. Just treat the hyponatremia when the patient have a severe symptom. we don't want to rise the sodium level too fast. And this is an initial path for critical hyponatremia from pulmonary. After we check for the sodium level and it's low, we will check for the serum osmolality, urine osmolality, urine sodium. We can repeat the electrolyte and the TSS and cortisol level. Prevent further water intake, like restrict oral fluid intake, and avoid admit any hypotonic or isotonic fluid. So this is research that among the patients present with the severe hyponatremia, the rapid correction occur in 41% of all the patients. And the osmotic demyelination syndrome is not common, but they are grouped with the higher risk, like alcoholic are the particular vulnerable group. So what about the hypernatremia? With hypernatremia, they are higher than normal concentration of sodium in the blood. It's about 145 milliliters per liter. Sodium is the major determinant of serum osmolality, so it also leads to the high blood osmolality, usually over 200 milliosmol per kilogram. The symptom depend on the value of serum sodium and whether it's acute hypernatremia or chronic hypernatremia. Acute hypernatremia called neurological syndrome that range from lethargy, weakness, altered mental status, and irritability to severe syndrome like seizure or coma, even death. Acute hypernatremia rapidly pull water out of brain cell, so the brain as a whole shrink, and it can rupture the blood vessel and cause intrarenal or subrenal hemorrhage. The chronic hypernatremia, on the other hand, called mild syndrome because the progress happens more rapidly and there isn't the same rapid shift of the water. If an individual is hypervolemic, they clinical present with edema and caused most likely by sodium overload. With the hypovolemic individual, on the other hand, may present the sign of dehydration. However, the subtle clinical sign of dehydration can make it hard to diagnose it between the hypovolemic or euvolemic. So in the practice, the urine osmolality can help. Finally, the treatment for hypernatremia rely on admit the normoxilin or the dextrose to correct the water deficit and lower sodium level by maximum of 10 milliliters per day. Like hypernatremia, we will treat the hypernatremia when the patient have a severe symptom, and we will give the fluid until the perfusion deficit resolve, and after that we give the 0.45% natrium sodium chloride with euvolemic hypernatremia. We will give the desmopressin. So let's go to another case. 32-year-old patient with history of leukemia and recently started on chemotherapy, presently with nausea, light, lightheaded, zero weakness, and his vital sign almost normal with tachycardia, and we do an EKG show below. So what is the next step in manager of this patient? The first, can we give the fluid with calcium gluconate or perform a synchronized calibration or give insulin or sodium pickup? Yes, the answer is B. With this EKG, we see the big T wave, and the patient may have a hyperkalemia, and we want to treat the patient with admit the calcium gluconate. So with hyperkalemia, there are too much potassium in the extracellular fluid, generally over 5 mV per liter. The common cause include the renal failure, metabolic acidosis like DKA, or hyperlipemic hyperosmolar state. The use of the medication like spironolactone and NSAID or digoxin can cause that. And the cause may be the tissue breakdown, like in the trauma or the tumor lysis. Hyperkalemia is often symptomatic, but it can cause palpitation, muscle weakness, and arrhythmia. And the EKG can change with the big T wave or widened peer interval, while VRS duration. To temporary measure for the hyperkalemia emergency treatment, we will be the calcium to stabilize the myocardium, indicate the calcium in patient with the potassium larger than 6.5 or the trend in EKG. We will admit 1 to 3 gram calcium gluconate by IV or calcium chloride to a central venous line. After that, we will give the insulin with dextro, beta glucanase by nebulized, and we admit the bicarbonate in case of metabolic acidosis. And for the definite treatment, we can the patient need the dialysis. So we do you know about the potassium removal agent like furosemide or sodium polystyrene sulfonate, example like Electrolyte? Do you have experience about to use this? Anyone have a experience about using the potassium removing agents? So if no one has answer, in Chorai in the past we use the Kaya but it is no longer generally recommended because the limit evidence to demonstrate the benefit, but maybe called the power neurosis. So in Chorai now we don't use the Kaya in the ED. So this is the treatment of hyperkalemia via kaliuresis. We can admit the furosemide 20 to 40 milligram IV and can repeat it every 10 or 15 minutes if the patient, the symptom is not trend. Now going on, we will go to another case. It's 72 years old patient with history of heart failure and atrial fibrillation present in ED with malaria and weakness. Its medication include furosemide, warfarin, losartan, metoprolol. He reports that his arm feel heavy and can no longer walk without assistance. An EKG was obtained and so below. What is the most likely cause of patient syndrome in and the EKG? Yeah. Yeah, the answer is the cause of this patient may be the furosemide. We see the EKG show widespread ST depression and T-wave platonic inversion. This patient may have hypokalemia, and it is one cause is furosemide. Hypokalemia is not is a very common derailment, but not nearly a right pattern. The hypokalemia is the serum potassium below than 3.5 milligram per liter. It can be a syndrome or syndrome like palpitation or muscle weakness and an EKG illness. The EKG abnormal include extra segment depression low T wave, and increase the U wave amplitude. For the treatment, always check the magnesium to replace its flow because the magnesium required for sodium and potassium pump. When potassium is below 3 millidegree, or when the individual with the symptom, we will give the potassium chloride by IV. Admit 20 milligrams per hour potassium chloride to the peripheral line with the rate larger than 10 milligrams per hour. We require a central nervous access. So now we will go to another case. The patient have a history of chronic alcohol use, present with constipation and severe diarrhea. He had been having diarrhea for the past week and feel dehydrated. He report muscle spasm. His vital signs are normal, but we do an EKG like below. What is the most likely electrolyte derangement? Let's explain the patient condition and EKG. Yeah, this EKG show that there are run of ventricular tachycardia as well as ventricular atopic, which is during normal rhythm is 465 milliseconds. Normal serum magnesium level are generally considered to be 0.8 to 1 millimole per liter. The hypomagnesium defined as the level of magnesium lower than 0.8 millimole per liter and is associated with QT interval prolongation and risk of ventricular arrhythmias. With magnesium disorder are less common. The hypermagnesium is very uncommon. We should check the magnesium level when patients have symptoms about like weakness, confused, seizure, and remember when the patient have an electrolyte disorder, especially the hypokalemia, we should check the magnesium disorder. And with hypomagnesium treatment, we will feed magnesium sulfate, and with the hypermagnesium treatment, IV fluid resuscitation is needed, and we can admit the furosemide, calcium chloride, or calcium gluconate. And if the patient have a severe syndrome like hypotension, heart block, cardiac arrest, maybe we need to dialysis. So now we go to the hypercalcemia. Hypercalcemia can caused by primary hyperparathyroidism or hypercalcemia of malignant. The hypercalcemia occur when the it's about 10 10.5 milligram per deciliter or 2.6 or less than 2.6 millimole per liter. The patient with hypercalcemia present with can be present without syndrome or are detected incidentally, but the syndrome of patient classically present with the following mnemonic: stone, bone, run, thrown, saturated over stone. The patient can have a renal stone, uh, the skeleton maybe bone bend and abdominal prone. The patient maybe have a nausea, vomiting, abdominal pain, or even pancreatitis. The throat, the patient may have a polyuria, polydipsia, dehydration, constipation, and psychiatric overtone like lethargy, mental status, coma. For the hypercalcemia treatment, we will give Louis admit the conjugate 0.5% sodium chloride IV at 200 to 300 milliliter per hour to maintain the urine output of 2 liters per day. If the equate hydration, consider admit the calcitonin to further decrease patient calcium level. We can admit the calcitonin to unit per kilogram intramuscular or subcutaneous 12 hour, every 12 hours. In the patient with hypercalcemia of malignant, P-phosphate should be considered after fluid resection. The and if the symptom is not decreased, maybe we should concern with the neurotic for emergency hemodialysis. With the patient with hypocalcemia, we can examine, we can find the two cell size. Hit the capsule after the blood pressure cuff inflated to 20 millircurie above the systolic blood pressure for 2 minutes. And you can see the hand of patient like that. Or you can find the triple test size when the facial or eye muscle twitching after we tapping the facial nerves. And the patient with hypocalcemia can develop cardiovascular effect with a prolonged VT interval, lead to ventricular dyspnea, heart block, or cardiovascular collapse, even cardiac arrest. IV calcium recommend in the patient with moderate to severe syndrome like tetany, seizure, and calcium gluconate can be used. Now we go to the phosphate disorder. Let's see, it rarely and in emergency of Jarai, we do not measure the phosphate level in the practice, so it's new. But remember, with the hypophosphate, the etiology may be repeating syndrome, DKA, dialysis, or with vitamin D deficiencies, and the symptom may be weakness, seizure. The treatment for hypophosphate, when the patient have a phosphorus lower than 1.5, and we can go admit the sodium or potassium sulfate. With the hyperphosphate, in the patient with tumor lysis, renal failure, with symptom of fatigue, shortness, breath, or vomiting, we should give fluid for resuscitation and give the phosphate binder like acetazolamide, and if not work, we need to dialysis. This is the repeating syndrome when the severe malnourished patient is given glucose, the following cascade event take place. Insulin irregularly. This stimulates drive to produce ATP. As ATP produce, phosphorus is depleted. As ATP produce, the cellular sodium and potassium phosphate is active and leading to transcellular movement of potassium and eventually other electrolytes include magnesium, phosphorus, and calcium into the cell, lead to the hypokalemia, hypomagnesium, hypophosphatemia. The metabolic acidosis also develop. And so this is the summary for this talk. Thank you for your patience and for listening. So anyone have a question? Xong rồi. Chết ngủ rồi. Cảm ơn các bạn nha. Bài này nó nó dài, nó cũng hơi phức tạp. Hai là từ chuyên ngành phát âm tiêu chuẩn lắm, nhưng mà cố gắng ờ, học tập, học hỏi thêm, phát triển thêm. Còn bạn nào có thắc mắc tiếng Việt thì